I'd like to acknowledge the Laku custodians of the land on which we meet today and honour elders past, present and emerging. I'm Melissa Wilkinson from the PHN, the education team. Welcome tonight to Cancer Screening Quality Improvement Approach. We have Kath Duggan tonight with us, who works at the Cancer Institute, and she's leading the primary care team there and is a strategic advisor. And we also have Amy Callahan with us, who's the PCIO at the PHN. Lost there. Welcome. I'd like to just do some housekeeping as well. Please remain on mute. We will have a poll at the end of the session for you, and we really value feedback, so please complete that as well. If you have any questions, we'd like to encourage questions. If you could enter those into the question or chat box, that would be amazing too. We will refer to those at the end of the session. And if we don't get time or we run out of time, we will email a reply to those questions that are entered into that box. So without further ado, I will hand over to Catherine Duggan. Welcome, Catherine. Over to you.
Thanks, Mel. Thank you very much for inviting me to come along tonight. It's great to be here. Hopefully everyone's home from work and warm, and it's a bit chilly and rainy out there. So tonight we're going to step through the cancer screening quality improvement presentation, and then so I'll sort of give an overview of the cancer screening programs, and Amy will come through after my presentation and provide some in practice cancer screening and information that will be really hopefully user friendly for you. So I'll get underway. Just make my slides work. All seems good at the time. So I'd like to begin by acknowledging the traditional custodians of the lands on which we're all living and working, and for me today it's the land of the Wanneroo people, and I recognise their continuing connection to land, water and community, and I pay my respects to elders past, present and emerging. So just to give you a quick overview, so Cancer Institute New South Wales, where I work in the primary care team and work as the primary care strategic advisor representing, I guess, primary care and advocating for primary care in the cancer control space. So the Cancer Institute is a pillar of New South Wales Health, of which there's 5 pillars, and our main role is, sorry, I'm just moving some things off my screen so I can read it. Our mission is to working together to lessen the impact of cancer, and there's a focus on cancer screening, cancer prevention, early detection, diagnosis, treatment and care. So Cancer Institute recognises the very valuable and important role of the primary care sector, and in our upcoming cancer plan, which is a 5-year plan, this is even becoming even more important as a very important place to focus on cancer control. Just wanted to also, in saying that this year, in March this year, we launched our primary healthcare cancer framework for New South Wales. And previously, or up until now, there has been a large focus and continues to be a large focus on cancer screening, but the Cancer Institute really recognises that role of primary care in cancer control more broadly, so prevention, screening, early detection and diagnosis, treatment, survivorship, palliative and end-of-life care. So we've developed a framework, as I said, which we launched this year. And I will say too, all these slides will be available on the Community of Practice webpage, and there's hyperlinks throughout the presentation, so you can click through to visit any of this information following the presentation. So I have put the link here to the launch of the event that we had in March, and there's some great keynote speakers, one of them which is Norman Swan, who hosted the event. And so it was really great to be able to get this framework out. And just to acknowledge that 85% of cancers that are diagnosed are following a symptomatic presentation to primary care. So we know it's a significant role that primary care plays. Equally significant is the role of primary care in cancer screening, with 60% of patients surveyed reporting that they were more likely to participate in screening if they were reminded or encouraged by their GP or their primary care provider, and not just the cancer screening registers or letters only. General practice is uniquely positioned because they have patient information, they have their patient data, they know who their patients are, they have relationships with their patients. So encouraging them to participate, particularly for those who are underscreened or never screened, is really a great place for this encouragement to occur. And just as a little bit of evidence, the Green Book, or RSEGP Green Book, says that reminders are the only patient intervention rated as very effective to improve participation in screening. So we have 3 population cancer screening programs in Australia. So we have the National Cervical Screening Program, the National Breast Screening Program, and the National Bowel Cancer Screening Program. I just on this slide have highlighted that BreastScreen, there's BreastScreen Australia, but we also have BreastScreen New South Wales. So specifically, BreastScreen in Australia operates and is funded through state-based funding, so through local health districts. So when looking for your information specifically about BreastScreen, it's great to visit the BreastScreen New South Wales site, which is coordinated and through Cancer Institute New South Wales. So all of those are hyperlinked. When we're talking about national screening, we're talking about population screening programs. So that's basically programs that when delivered in a particular age group is the way in which we are able to provide earlier diagnosis for cancer. So the first screening program I'll talk about is BreastScreen. So BreastScreen New South Wales is for women targeted at women aged 50 to 74 years old who are invited to participate in participate and attend for a screening mammogram every 2 years. So it's 1 in 7 women will develop breast cancer in their lifetime or over the before the age of 85, and so this was 1 in 8. So we really know that more women are being diagnosed, but what we want to happen is that women are diagnosed at a very early stage so that their treatment and outcomes can be much better. BreastScreen New South Wales have a very robust system of invitation and send letters in the mail. I think you get, and this is from personal experience, you receive 2 letters, an SMS, and if you haven't responded, you will also receive a phone call. But despite all of that, we still only have 50% participation in BreastScreen. So that encouraging voice from primary care is really important in encouraging women to participate in BreastScreen. Oh, and I should have just said, you don't need to have a referral to BreastScreen. You can participate self-referral, but there is some tear-off referral pads that primary care can use that do encourage women to, it's that little extra encouragement to participate. So the cervical screening test, or became the cervical screening test from the used to be the PAP test, and that changed in 2017 following the renewal program. And the cervical screening test is aimed at detecting the human papillomavirus, and we do know that 99% of cervical cancer is caused by the human papillomavirus. The test is for women aged 25 to 74, and the test is every 5 years if you have a negative result. Following the clinical guidelines, if there is varying callbacks and reminders and recalls, if women have differing results or inconclusive results. So it's very important when receiving the results back to practice to set appropriate reminders and recalls for women according to their test results. We do know that the incidence of cervical cancer is much lower than our other cancers. However, it's still 1 in 200 who will develop cervical cancer before the age of 75. We do know that our cervical screening participation rate is a little higher than the other screening programs, but still 4 in 10 women that are eligible are still overdue for their screening. Tonight, we will focus a little bit more on the National Bowel Cancer Screening Program. And as Amy and I felt that being Bowel Cancer Awareness Month, it was a good opportunity to do a little bit more deeper dive into the bowel screening program and highlight this as a quality improvement activity. So the National Bowel Cancer Screening Program sends free bowel cancer screening test kits in the mail, and you may have seen Norman Swan and a lot of the ads on TV where he's coming up to the door, basically, we've done everything we can to encourage people to participate, but now you've got to do your part. So the test kit arrives in the mail every 2 years for people aged 50 to 74 years of age. I've put the link down the bottom of this page to the Do the Test website. So we do know that bowel cancer is Australia's second biggest cancer killer, and 91% of bowel cancers are found in people aged over 50. Hence, our screening participation or eligibility range is 50 to 74 years of age. Another important note when we're looking at bowel cancer screening, and particularly when we're targeting and looking to improve participation, is our screening participation is lower in men than women. And so this slide shows that consecutively over a 10-year period, women screened at a greater rate than their male counterparts. And this slide also shows, this is New South Wales participation in bowel screening, and we've broken that down into age groups. And I hope you can see that slide okay. But where you see there, and I probably could have moved my arrow a little bit further, but you'll see that the age 50 to 54-year-old age cohort, and the blue bar there is male participation, is only 26.9% participation. So it is certainly a lot lower for that cohort. So it's really important to encourage that group to, because they've just started screening, they're just eligible to actually participate, because it's oftentimes once you get started, you know, the next time it comes in the mail, oh, that's right, I know what I'm doing, I've done this before, it becomes a lot easier, but it's just oftentimes that first one is a little bit trickier. So really encouraging that male, younger age cohort to get screening is really important. We do know that the primary care does play a very important role in encouraging people to participate in screening. So building that encouragement into health assessments. So when people come in for their regular checkups, for if they're having a health assessment for Aboriginal people, if it's a 715 health assessment, asking about if they've done their bowel test, checking in that they've participated. There's also on in the national program page information and templates for reminder letters, for SMS templates. There's also some great information for online training and clinical resources. And for any nurses online tonight, APNA have a great 1-hour presentation on the bowel screening program, which is really great CPD to attend to. So that's, and I do think it's free. I don't think you have to be a member of APNA to access that training. So I encourage you to go to the National Bowel Cancer Screening Program webpage and have a look at the information there. There's great resources for general practice. There's in-language resources. There's also links to the National Indigenous Bowel Cancer Screening Program. So really great resources for supporting and encouraging Aboriginal patients to participate in screening. And I think the blue call-out box here is really highlights that bowel screening participation rates, if they can be increased to 60%, almost 83,800 lives could be saved from bowel cancer over 25 years. So it's a significant improvement in lives lost. So really focusing on increasing that participation is going to have a significant outcome for your patient group. I was just going to touch on how the actual system works. So when a patient receives a positive bowel screening result, you as the primary care provider or general practice will receive the result as well. And the patient receives the result, most patients will then contact their primary care provider to attend for appointment and to understand referral to colonoscopy and how that occurs. The National Bowel Screening Program has a function called the patient follow-up function, and that's there to catch people who don't actually get followed up by their who don't make contact with their primary care provider. So they're caught in a net, I guess, and I'm encouraged to participate in colonoscopy. So that's a really great safety net, but a really important also that primary care reaches out as a clinically significant result to follow up with their patients as a responsibility. So Cancer Institute, just as a little bit of background, and this is probably how I arrived in my role. I actually used to work at Hunter New England Central Coast PHN in the cancer screening program, and was part of developing the Hunter New England Central Coast Cancer Screening Toolkit. And so across New South Wales, another 10 PHNs were beavering away doing something very similar. So Cancer Institute 3 years ago, brought together all the great learnings across New South Wales into one toolkit called a Cancer Screening Quality Improvement Toolkit. So this at the present time has a focus on breast, bowel and cervical screening, has that principle and foundation of integration. So really looking at the importance of bringing cancer screening into your business as usual, because we know that primary care is very busy with lots of competing priorities and areas of patient care. So we're really looking at supporting that integrated approach. The existing toolkit contains great information on improving data and systems, data cleaning and analysis, so linking to your software and how to on improving cancer screening participation data, your recall and reminder systems, taking that quality improvement approach, so really great information there on quality improvement cycles, so plan, do, study, act cycles, really looking at applying that whole of practice approach. So, you know, the champion, who do you have a champion in your practice? What's the role of the GP? What's the role of the practice nurse? What's the role of the practice manager and staff who have a very integral role in maintaining that patient data and patient information, and obviously taking that person-centered approach. So the toolkit as it is a screening toolkit, and that is on our website at the moment. But what we're looking at doing, or in the throes of doing, is simplifying it a little, so really pulling it out just to be 3 separate modules of breast, bowel and cervical screening. And the aim of this is that we will broadening the focus from not just a cancer screening toolkit, but a primary care toolkit, so that we can add on prevention modules and other modules going forward. Going back to that first slide of our circular diagram where we had that focus on more broadly than screening, but across the whole of the cancer continuum. So watch out for that smoking cessation module. I just wanted to highlight to you also that it's very important to understand the patient population that you have attending your practice, for the reason that many people in our community are participating in cancer screening at a different rate. So we know that at Aboriginal and Torres Strait Islander people participate in bowel screening, for example, at a much lower rate, actually half the rate. So the actual national average is around 46% of participation for non-Aboriginal people, but for Aboriginal and Torres Strait Islander, that's around the 26% mark. So that's significantly lower. We know that screening across our multicultural and refugee population is also lower, and across our other focus populations. I have put a hyperlink in there that you can click through, and you can actually look at that information more carefully. So if you're in a rural area, we know that people living remotely have a lower participation rate. So it's taking into account our patient population and really drilling down onto particular groups to help improve that participation rate. Some of the resources that we thought we'd highlight to assist you. So some of you may be aware of the National Cancer Screening Register that's now has an integrated portal to primary care. And Amy's going to talk a little bit more about accessing the portal and about the register, but I've just put a hyperlink there which takes you to the portal user guide. There's some really great starting guides there, so getting started and understanding the portal, understanding the information, how to access, but there's also some great little videos there too, so it really steps you through how to use the National Register. The National Register is there to access participation data for the National Bowel Screening Program and the Cervical Screening Program. I also wanted to highlight a resource when the original primary care cancer screening toolkit was developed by the Cancer Institute. PenCS joined up with us and developed this great resource that's full of recipes to help improve or identify your patient data for the cancer screening programs. And I know Amy's going to talk a little bit more about those in the coming slides. I also wanted to highlight to you some of the great resources that are out there that are offered by RSCGP and that you may already be familiar with. But the Red Book, which has our clinical guidelines and supports around prevention and screening in primary care. Our Green Book, which is really putting that prevention into practice, so information on quality improvement, taking that team-based approach, and really great information about putting health promotion, taking that prevention approach. The National Guide to Preventive Health and Assessment for Aboriginal and Torres Strait Islander people. This is a great resource that supports the 715 health assessment. Really great information and evidence in support of that, undertaking that assessment. And also our accreditation guidelines, which highlight the importance of health promotion, taking a family history, and having that quality improvement approach, and appointing a quality improvement champion are all recommendations under the accreditation guidelines. This checklist is in the toolkit that we have on the Cancer Institute website, and I've provided the hyperlink there. And going back a few years, so Amy and I used to work together, and in bringing together the toolkit, this was one of the first tools that we put together, we found was most useful out in primary care. And this tool has been adopted by the Cancer Institute and on their website and within the toolkit. So it's a great place to sort of do a bit of a check-in to see where you're up to as a practice. If you haven't done a lot with cancer screening, it's a great place to start to see where you might like to make some changes. So I'd really encourage you, if you haven't, or if you've sort of done some things, but you'd like to do a bit of a, I guess, a bit of a check-up on where you're at in terms of cancer screening, this is a great tool to use. I also want to highlight some of the great resources that Cancer Institute have that can support you, and you can order these online or download, is the in-language resources. And I'd also like to show this patient information. So these are the sites within the Cancer Institute site. So a great patient information site. Everq have great treatment protocols, and particularly for our GPs to check in if they've got a patient who is undergoing treatment. They can look in to see what that treatment is and maybe some other side effects and how they can support that patient during their treatment. Everq Education has some really great modules and information on cancer care and treatment. Our CanRefer has great information there, particularly around that referral from when a patient is diagnosed through into a multidisciplinary team or a high volume cancer centre, so that they're assured of a high quality care and access to a multidisciplinary team. We also have our screening programs and also the base for the quit line, so I can quit information. So a real wealth of information for you in terms of for cancer control. I'd also like to just finally finish with, when we launched our framework this year, we really recognised that primary care needed that one-stop shop. So when you come to the Cancer Institute for information, just to come to one page, which is the Cancer Institute, what we do working with primary care, and come into that page and you've got all the tiles there that step through the cancer control continuum and take you to the relevant information for primary care, for clinicians and for patients. So I hope that's given, I know it's a kind of, there's so much information there, and just to give you a quick overview of what the Cancer Institute does and how we value and highlight the important role of primary care in not only cancer screening, but cancer control more broadly. So I'll just, I'll pop my slide up there, my information and details there for our team. So we have a primary care email address as well as my own details. So if there's anything that I covered tonight or didn't cover, or you'd like more information, please reach out or give us a call. We'd only be too pleased to help. And thank you very much. I'll hand over to Amy.
Thanks so much, Kath. And just a reminder, if you have any questions, to pop them into the chat box, and we'll get to those at the end of the session. And we'll now hand over to Amy. Thanks, Amy.
Hi, bear with me. Can you see my
Looks great.
screen? Fabulous. Now, I just want to quickly say thank you to Kath. She's been a wonderful friend and colleague to work with, and she has a wealth of knowledge in the cancer screening space. So please do take her up on the offer if you have any questions about her presentation. So as Kath mentioned, it is Bowel Cancer Awareness Month, and it is timely that we focus on bowel screening. So what do we know? I just want to reiterate a few points that Kath obviously went over as well. We know that 8 out of 10 people who are eligible aren't participating in the National Bowel Screening Program, that 1 in 13 men and 1 in 16 women who are diagnosed with bowel cancer during their lifetime in New South Wales. Screening participation is actually lower in males than females as well. So just a really quick overview of our PHN's participation rates. We are slightly above the New South Wales rate and we're slightly under the national rate. So we're sitting in a really good space, but there's always room for improvement and to improve our own screening rate. So how do we really translate these stats and identify patients who are due or overdue for bowel screening? So there is an enormous amount of data that is available. Sorry, I will just have to hide myself because I'm a bit of a lag back here, so I do apologise. But there isn't a large amount of data that's available, and there are ways that we can use this to improve our cancer screening. For example, I've displayed 2 reports on the screen that you should see, which have both been developed by the PHN. The first is a population health snapshot, and the second is a general practice dashboard report. The population health snapshots are available for all LGAs and available on our PHN website. They include a wide range of data such as chronic disease and mental health rates, access to services, as well as cancer incidence, mortality, and cancer screening participation. What really draws me to these reports, and I love data, is that looking at from a cancer screening perspective, in the Central Coast local government area, just under 18,000 people aren't screened for bowel cancer, meaning that between the ages of 50 and 74, these people have not participated in the bowel screening program, which is quite significant. So how does this snapshot directly relate to your patients in your community? And possibly of these 18,000 under-screened people, do you have an opportunity to encourage participation in the bowel screening program? The second dashboard report, which is a de-identified dashboard report that you will receive on a regular basis from your primary care improvement officer. If you haven't received the most recent report, please reach out to your PCO and they'll be more than happy to share that report with you. But once again, this report shows patient demographic data, lifestyle risks, disease prevalence, MBS and quality improvement measures, but also more specifically cancer screening data. So what I've done is highlighted the bowel screening section of this graph, and as a quick overview of what this data means, the eligible patients are noted in the blue column, and they're the number of males and females aged 50 to 74 who are eligible to participate in the National Bowel Screening Program. The ineligible patients in the light orange are the number of males and females who have been excluded from screening. Now, CAT4 has developed an exclusion list for colorectal regions, and that's on their website if you'd like to have more information around those exclusions. The total number is noted in green, and these are the number of patients who have a pathology result recorded accurately in their patient file. So these pathology results are GP initiated screening, not through the National Bowel Screening Program. The not recorded in orange is the number of males and females who have not been screened either via the National Bowel Screening Program or the General Practice Initiated Screening. In maroon is the National Bowel Screening, so that's the patients who have acted on the kit they receive in the mail. And the overdue are the patients in yellow. So these are the number of males and females who have not been screened in the last 2 years. So when we're reviewing this data, please be aware of the potential discrepancies in data. So it's the old saying of rubbish in, rubbish out. So if you're not recording the data in the correct places, or your results aren't coming through in the HL7 format, which is the way they come into your computer system, the data won't sync correctly to be extracted into PEN. Don't worry about these little nitty gritties. We can actually work through that with you if that is a potential problem for you. So your participation rates may slightly differ from what's available in these reports. But we have LGA data, we have practice data to educate, remind and encourage our patients to participate in screening, but what do we really do with all this data? It can be quite overwhelming, but we can actually translate this data into engaging our patients. So there are two fabulous tools, and one of them Kath has already mentioned, is the National Cancer Screening Register and CAT4, which you all should have access to. If you don't have access to your CAT4 tool, please reach out to one of your PCOs and we'd be more than happy to ensure that we can get you on board to be able to access your data. So through CAT4, really briefly, we can extract meaningful data to identify patients specifically around their screening activities. But in the National Cancer Register, we can identify patients and look at their screening journey. So we can see if they're up to date with their screening, whether they are due. It's a fabulous tool to be able to access and utilise in your practice. So really quickly, and if you're unfamiliar with CAT4, I will just go through just quick functions of how to extract specific report around bowel screening. So from my screen, we're going left to right, and maybe the other way on your screen. So we're looking at the general tab. We're selecting our age range, which is 50 to 74, and we're wanting to look at our active patients. So active is what our ACGP accreditation standards go by, which is a patient visiting our practice 3 times in 2 years. So in the right-hand corner, we're clicking recalculate. So once we go down, we can select the screening option, FOBT, and FOBT last reported. So what we've done is we've identified all of our males and females in your practice between the ages of 50 and 74 who are eligible to participate in the National Bowel Screening Program. So this is where we can identify the patients you have regular contact with. So in the grey section, as you can see, we have just under 900 patients who've been identified who do not have a bowel screening result recorded. So you can't actually, we talk about PEN and using it in a meaningful way. We can't effectively engage with 900 patients to encourage participation in bowel screening. It's quite a large cohort of patients. If you send an SMS out or a reminder letter saying they're due for screening, would it be effective, or would you have hundreds of patients calling your practice, requesting an appointment with your GP or wanting to speak to your nurse? You've got to look at PEN in a workforce and capacity view as well. So when you're focusing on any screening program, you need to consider looking at your patient population group. So similar to what Kath was saying about looking at your patient populations, you can look at your patients who identify as Aboriginal or Torres Strait Islander. You can look at patients with an outstanding FOBT pathology request. You can look at either males or females who are too overdue for their screening, those who have just turned 50 and have been recently been invited to participate in the program, or you can then look at your males or females who are 70 to 74, who are coming towards the end of their screening program and offer them an exit screen. By manipulating the filters, such as the sex, so changing from male to female, or the ethnicity of your patients, we can create smaller lists to engage with. So instead of having 900 patients we're looking at, we can look at a smaller list of patients. So I have done just that. So what I've done, because we've noted that males are screening less than females, and the fact that we can actually really engage with patients early on to continue screening habits, I've selected males aged from 50 to 55, are active patients, and we're now actually looking at a list of 84 patients who have not been screened. So out of 1,600 patients, we've drilled it down just this activity to look at 84 patients. So we're actively engaging with these patients in a meaningful way, and it's significantly more manageable. So what can we actually do once we've drilled down this far? So the evidence shows that when patients are reminded by their GP to continue with their screening, they're more likely to screen. So you are in a very unique position to have an impact on a patient's screening journey. So you can look at it a few ways and how you're actually working with your patients. You can go with a general approach. So you can remind your patients who are due for screening via an SMS or a letter, whatever your preferred method of contact with your patients are. You can incorporate screening discussions into your routine consults, and you can use your clinical software to use prompts and alerts in your clinical software as well. You can use your social media platforms to promote screening. So the New South Wales Cancer Institute and the Bowel Screening Program have fabulous Facebook and Instagram tiles that you can share on your own platforms as well. You can include screening prompts in your health assessment and management plans, display posters and information in your waiting room. And what a really important one is actually is undertaking the family history questionnaire. So there is an enormous way to engage with your patients around screening. But we could take a different approach. And for me, this approach is nearly step one now that it's up and running, which is the National Cancer Screening Register, which I'm very excited about. And it is a fabulous tool to utilise to ensure your patients are up to date with their screening. So the screening register is basically one register that hosts health information regarding the National Bowel and Cervical Screening Programs. So basically, it's an electronic record for all eligible men and women participating in either or, screening programs. So the main function of the register is to send invitation reminders letters to your patients. It allows you as a clinician to support the patient by deferring screening through the record, through the register, and you can update and you can access also screening history and results. So, for example, with those 84 patients we identified between the 50 and 54-year-old mark, you can actually utilise the register first, look at their file within the register, see if they have been screened, and update your own clinical system to reflect the accurate information in the register. So you're not actually contacting that patient to encourage them to be screening when they've already been done in the last 2 years. So to access the register, it can be done in one of three ways. The healthcare provider portal, through integrated clinical software, or the contact centre. So the contact centre is available Monday to Friday during work hours on the 1-800 number noted on my slide. The integrated clinical software, at present, the register is only integrated with best practice at the moment, with medical director coming on the next few months. And obviously other software, clinical software will come on board once they have worked out those little IT bugs in between. So the main way you'll be able to access the portal, the register, and the most preferred way is through the healthcare provider portal. So in the portal, you'll be able to access your patient bowel and cervical screening results and history. You'll be able to submit forms and reports electronically, not via snail mail anymore. You'll be able to update information regarding the patient's participation, including their actual personal details. And really excitingly, you will be able to order FOBT kits through the register. So you can have a patient in your consult room having a conversation to encourage them to commence screening, or even ask if they've received their kit yet, if they've lost it or they've haven't received it yet. In that consult, you can actually request that kit to be sent to their home address, and you'll be able to ensure that their address is correct in the register as well, which is very exciting. So the biggest thing is actually how you access the portal. This is done through Proda. So before trying to access the portal, there is a few things that need to be done. So your GP will need to have a Proda account created. It could only take 5–10 minutes. It's very simple to create if they don't have one already. They will need to ensure that their provider number, and their health professional identifier number are linked. You'll also need to make sure that their HPOS account and the general practice healthcare professional online organisation number is linked as well. If that doesn't make any sense to you, that is completely fine. It can be very foreign to people, but please don't worry. You can either do one of two things. You can contact the Proda hotline, you can contact the Healthcare Identifier Service, or your primary care improvement officer is more than happy to assist you ensure you get access to the register. It can be a little bit clunky, it can be a bit confusing, but there are really simple ways that we can connect you to the portal. So once your GP has connected successfully, then you can go ahead and you can delegate access to your admin or your clinical team as well. But please don't hesitate in contacting your primary care improvement officer if you have any issues accessing the portal, and we can work through them with you. So I have shared an enormous amount of information in a very short period of time, but I guess it's just a really quick snapshot of actually how we can support you. There are numerous activities that you can undertake when it comes to screening, cancer screening, and improving your screening participation rates. So what we actually would like to do is that we can work with you in your practice. And there are some key things that we can work through with you. The first is being we can establish accurate bowel, breast and cervical screening participation rates within your practice. We can help you analyse and interpret your cancer screening data through CAP4 and identify your patients who are due or overdue for screening. We can help you access and maximise the function of the National Cancer Screening Register. We can help you develop robust recall reminder workflow systems. So all those fun things like data cleansing and coding and ensuring all the data is coming correctly to reflect what's happening in your practice. And we can assist you implement effective patient engagement strategies. So not every practice is the exact same. The way you engage with your patients and what's successful in one won't be successful in another. So we are able to help you identify what's going to work best for you. And in these areas as well, these can lend to other areas such as chronic disease management. The principles you learn through undertaking these activities, you can relay into other areas as well. So what we provide in support actually does contribute to your compliance in a few other areas as well. So while we're looking at your bowel screening or breast screening, it's actually working towards your quality improvement incentives. So we have fabulous examples to show you and to share of how to write up a PDSA cycle and a plan of how to improve screening rates or look at any area in your practice as part of a quality improvement activity. So specifically, you can be looking at your cervical screening as a quality improvement measure, but you also can be looking at bowel and breast for that quality improvement incentive. Obviously, with the changes with the 5th edition standards, quality improvement have a very significant part to play in the standards at the moment. So we can provide compliance with quality improvement in that area, and as well as the My Health records. So ensuring your clinical coding is up to date, that relates straight back to that requirement as well. So the support we provide does actually cover a range of areas as well. So as Kath mentioned as well, we have some fabulous resources. So I'm not going to dwell too much on this, but we do have a fabulous dashboard report. So if you're not receiving those reports, please speak to your primary care improvement officer. The population health snapshots are available on our website, near the What Do We Do in the planning section. As Kath mentioned, the New South Wales Cancer Institute website has a wealth of information, tools, which can assist you guide your activities and even educate you on the screening programs as well. We are actually reviewing our communities of practice, so we will be having a very specific cancer screening community of practice, which will have a large range of resources from quality improvement activities to how to assist you do data cleansing, how to utilise your staff, undertaking family history questionnaires. So it is going to be quite a fabulous space. We will be having community practice not just on cancer screening, but on immunisation, mental health, practice nursing, management. So it's a very exciting space that we're moving into. Obviously, our health pathways and patient information sites. So our health pathways do have our clinical guidelines and referral pathways, and Patient Info has some fabulous resources to help engage your patients as well. And along with Pen CS, so the fabulous document that Kath shared on her screen in her presentation about setting up cancer screening. There's fabulous recipes, along with the information regarding how data is actually extracted from Pen into, through a clinical system into Pen. So all of those things that I mentioned before about your patient's data, ensuring that data is going correctly, that's all in those reports as well. So if you do have any questions, I do appreciate your time on a Tuesday evening. But if there's any questions, I think it's a fabulous time to start. Mel?
Thanks, Amy. That was really comprehensive. And I'm just having a little look. If anyone does have any questions, could you pop them into the chat box or the question box, and we'll endeavour to answer them now for you. I'll just give you a couple of minutes to pop them in. But you did cover a lot of content. Both you and Kath was very comprehensive tonight, so I'm not surprised the questions have been a bit slow coming in. I'll just give everyone a couple of minutes in case there's anything anyone wants to ask. And a reminder that we are being recorded tonight, and a copy of the recording will be available on our website in the Education Library at www.thephm.com.au. Okay, it looks like everything was covered. If anyone has any questions that you come to mind after the session, please forward them to us via email, and we'll respond to you that way. But looks like it's no questions coming through, so it looks like you've covered everything. Well done, Amy and Kathy. All right, I'll speak to you both soon. Thank you everyone for attending tonight. Have a lovely evening, and thanks to everyone. Good night.
Thank you, Mel. Thank you, Amy. Good night.
Thanks, Amy. Thanks, Kath.